Hi, everyone. I'm Trina Fife. I'm the University Librarian at UNBC. Welcome to this session called Decolonizing Healthcare Education and Practice Through Arts, Nature, and Cultural Safety. We have three really amazing sessions coming up, or presentations. And the first one is, I lost my page with so many things open. The first one we're going to hear about is entitled We Are in Nature, Integrating Art and Nature into Healthcare Practice and Education in Northern BC, from Sasha Wade, Judy April, and Christina McKenzie. So I will be setting the timer, and I will try and keep everyone on time. All right. So whenever you're ready, go for it. Thank you.
Great. Thanks so much, Trina. Welcome, everybody. I'd like to begin by inviting you to just think back to the last time that you felt truly at ease in nature. Maybe it was raking the leaves, enjoying a moment of sun on your face, breathing in the crisp morning air as you walked across the parking lot this morning. Healthcare research is increasingly affirming what Indigenous knowledge has long taught us: connection to nature, opportunities for creative expression, and cultural belonging are essential to health. Nature time is now often described as the fourth pillar of health, alongside nutrition, exercise, and sleep. Evidence shows that time in green spaces lowers cortisol and blood pressure, strengthens immune function, and improves your mood, cognition, and social connection. Arts-based engagement, so things like music, painting, storytelling, all have a similar impact. And not surprisingly, healthcare providers who are targeted with these interventions develop stronger empathy, sharper observation, reduce burnout, and improve resilience. We know high-quality care must reflect cultural humility and partnership. When healthcare teams learn together across disciplines and with communities, empathy, trust, and patient outcomes all improve. So all of this growing evidence raised an important question for our team. How can we bring these principles of art, nature, culture, and community into everyday healthcare practice for our staff? Oh, you got to unmute.
Yeah, thanks. So we are a unique interdisciplinary allied health team, Chris, Sasha, and myself. And we have a longstanding mandate to improve the quality of care for older adults in long-term care. And our work is grounded in the evidence-based practice and knowledge translation. And we continue to ask, how can we do better? So in 2024, our team was inspired by that compelling evidence that Sasha was talking about and the emphasis on community partnerships highlighted at the BC Health Quality Forum. So in response to that, we collaborated with local partners to develop an art and nature-based healthcare workshop. The workshop was designed specifically for regional leaders and long-term care staff. So our workshop objectives were aimed at enhancing healthcare professionals' awareness, confidence, and knowledge in applying the holistic approaches and to deliver this knowledge through meaningful community partnerships. Incorporating art and nature into clinical practice also has the added benefit of honoring Northern Health's commitment to sustainability, recognizing that human health is deeply intertwined with the health of our planet. So this was a 2-day immersive event held in June of 2024, and the workshop was well attended. We had 30 people who attended both days, with an additional 10 people who attended day 2, which was held at Two Rivers Art Gallery. Day 1 was up at UNBC and included time in the beautiful botanical gardens on campus. As mentioned, this workshop couldn't have happened without community partnerships. In particular, we're grateful to have had Indigenous elders who provided us with a good start and closing to our workshop. We had a senior from Prince George who had a background in art and gardening, who also volunteers at the Botanical Gardens up at UMBC. And they took us through this lovely session of art making using nature as the canvas and the medium, and some nature-based meditation and reflection exercises. Staff at UNBC, some of whom are at this presentation today. So Sarah and Lisa, they led us in the Secret Pocket workshop, and that really provided that impactful learning on truth and reconciliation done through drama, art, dialogue, and discussion. We also had an OT from Australia. She calls herself the Nature OT, and she joined us virtually to teach again on that strong research base for the use of nature in clinical practice. Our other community partnership was with Two Rivers Art Gallery. They developed a session on visual thinking strategies, and you're going to hear more about that later in our presentation. We also participated in a painting session. We beaded medicine pouches, and we learned about Indigenous plant medicines. For more information, I'm going to upload the agenda into the chat, and then you can take a look at a more detailed description of the workshop agenda. So now let's hear more about how the workshop impacted participants.
Yeah, so we did sort of a standard evaluation just with a post-workshop survey. So it had 21 questions and it was completed by most of the 40 attendees, 85% of them. And as you can see, the results were overwhelmingly positive. So we had a 4.85 out of 5 overall star rating. And most people said that the workshop met or exceeded their expectations. Most people felt that they had an increase in knowledge, a change in perspective on how art, nature, and culture can be integrated into healthcare. And then we also collected some written feedback where there were some key themes: a need for nature in healthcare, in particular long-term care environments, the use of art for reflection and critical thinking, and cultural humility learned through Indigenous teachings, with a strong appreciation for hearing directly from elders, seniors, artists, and community partners. And we also heard that the level of community collaboration made the learning feel powerful, relevant, and grounded in real experience. And while these numbers and this feedback are meaningful, they only tell part of the story. And we actually had a partner from our simulation department at Northern Health video record parts of the workshop. And I was able to edit the pieces together that I was provided with to hopefully give everyone in the audience today a sense of the workshop and an opportunity to hear some of the testimonials and reflections. So let's take a look at what that impact sounds like and looks like. And I'm just wondering if I shared my sound as I'm. So I'm just going to stop because I don't think I did. And I'm going to just double check. Here we go. We are nature! Yay! Judy and I wanted to do this workshop primarily because we recognize that there is a benefit to art and nature in healthcare, in your personal wellness, seeing different perspectives and changing culture.
I think just the objective of sharing that out and inviting people in to do something like that, even if it might feel uncomfortable.
Or far, far too much. Too loud or too quiet. Too fierce or too weak. Conceptual art is what that's called.
And I don't feel like there's a lot of opportunity to attend workshops in person that relate to truth and reconciliation. And I find it something hard to search out on your own to do. So to have a space where I could come and hopefully take away some learning and some things that I can put into my practice was really important.
Pay attention to
you're part of the structure that interconnects us with the natural law of the universe and with each other.
I like to think of it that way, that we're all connected through this, and the energies that we give out, the energies that we put into our drums when we make them, that we put out with the drumming.
The Twin Rivers Art Gallery has an exhibit on right now around the incarcerated population in art. And there is a comparative photograph of the same individual over a period of time, from incarceration to the end of incarceration, and what their life looked like after. And it was amazing to see how people interpreted the photographs of that individual through each other's eyes. And it was through the conversations that, it reminded me of the importance of the centrality of the individual.
So it really deals with three simple questions, which is, what do you see? Why do you say that? And what else is going on? And the idea of that strategy is to help facilitate a conversation in which folks are building on their conversation with each other and coming to a compromised conclusion about what they're seeing.
Whenever a human being is involved, it comes with very different perspectives or very different maybe ways you can see their problem, or you can solve their problem. The solutions and the problems both have different perspectives.
Learning from other people's perspectives, and the whole idea that we all come with such different views and ways of seeing the same situation.
And we need to shift from just seeing the factual pieces into the narrative. That's very remarkable. And I really find it as important like this, so thank you.
None of us were wrong. We all looked at it and somebody would say something and I would be like, oh yeah, I can see that now.
Oh yeah, and it actually became very meaningful, like something that I'm actually going to remember and think about, and maybe even like evoke emotions, which I would never have if I just looked at it and walked on.
Usually I'll read what it's all about and think, what am I supposed to see? But instead, like taking the time to think, what do I need to see?
You can utilize your intuition just a little bit more and build that story and those facts and those lives with everybody involved.
I feel the need for the importance of people not only stepping out of institutions and getting onto the land and feeling just that wealth of knowledge that has been passed down for generations, teaching whether it's children or individuals that don't go out on the land, the importance of carrying medicine with you as a way of healing, as a way of respecting the land, and it hears around you.
And it was a way of learning that is new and outside of the box, but it also developed relationship, community, and sharing good practice.
I really want to thank the Allied Health Resource Team for putting this together. I think this is a great conference. I hope to see more of it in the future in Northern Health. And I'm sure that I will be taking it back to my educator team.
I think if you're hesitating to take this kind of workshop, that means you definitely need to take the workshop, because I think it's gonna light a spark in you and you're gonna feel excited to go back to work. That's what I feel.
We got to create some new connections, and it's good going to work and knowing that we're connected with so many people, and yeah, I feel ready to give again now, and I'm looking forward to incorporate some of these activities and teachings with clients and patients to help them feel good too.
I hear them saying, I want to take it back, and that's, I think, how things spread, and there's also that desire to keep it going.
Okay, so as we close, I just want to leave you with this image here to just appreciate one small example of the workshop's application. So on the left, we see what meals for someone with swallowing difficulties might look like in healthcare. It's pureed, modified for safety, carefully measured, meets physical requirements, looks quite clinical, but also potentially disconnected from what actually motivates someone to participate in eating. And then on the other side, we see what's possible when we integrate swallowing care with evidence-based creativity, culture, connection to nature. If you look carefully, we're still looking at pureed food there that's served in the shape representing its solid form. But it's not just about aesthetics. These are factors that directly influence a person's experience, their motivation to eat, their participation in care, and ultimately their health. So as a final reflection, clinical and technical precision in healthcare are undoubtedly essential. They ensure safety and skill. At the same time, we must also recognize that arts, nature, culture, and community influence clinical precision and clinical outcomes. Care that is person-centered can't be isolated from these concepts. And for many staff, these are new ideas, and although they're evidence-based, they're not yet universally accepted. Despite this significant barrier, our team was able to meet our objectives of building awareness and delivering a workshop in partnership with the community. And with gratitude, we'd also like to list all the presenters, partners, elders who made the workshop possible. You can look at our workshop agenda and all of the bios in the download section on the FeedLoop app. So that's everything.
Thank you so much. Yeah, that was amazing, and thank you for the video was a great way to demonstrate how, you know, what was involved, and I really loved I'm gonna paraphrase it, but like, if you're hesitant to take the workshop, that's why you should take the workshop. That was very powerful for me. I really like that, and for bringing it back to how this was implemented in practice. That was awesome. So I think we have time for maybe one or two questions. Anyone have any questions for the team? Yeah, Cindy.
I'm wondering if it would be like how possible it would be to have that workshop as a model that could be used throughout Northern Health and not just in Prince George.
Yeah, I mean, yeah, that's a really great question. Like, I think that we'd love to see this sort of workshop offered, you know, in other areas, in other regions of Northern Health, maybe, you know, with different community members that are sort of located in different regions and that kind of thing. But yeah, I mean, I think that it needs to be an organizational priority. And yeah, I think there needs to be someone dedicated in the organization who can sort of take that on. But that's a dream for us.
Thank you.
Yeah, Adita?
Yeah, so just curious, if you were able to do it again, would you kind of want to do the same workshop, or is there something that you would want to change or build on if you did it again?
I think what we were talking about when we were putting together this presentation is, you know, people were talking about taking it back, and we feel like this was a real just awareness part, and that's just like the very beginning. And so for it to we are trying to do a few things to kind of keep momentum going. We have a chat group of people who are interested in this type of work, and we you know, when we find articles, when we find news items that kind of relate to this area of practice, we put it in the chat, and people you know, they respond, and you can see that there's very excited people there, and that's kind of our first adopters, I think. And so in terms of another workshop and, you know, would we change it? I think there is still value in kind of this type of awareness workshop, but you know, maybe there can be different stages, right? For those who are really like in our little chat group, they're very much on board, and they, I think, would love to have some sort of other workshops that go a little bit more beyond this one.
And one other thing just to add to that is when Judy and I were reflecting on like what were the objectives of this workshop again, one of the objectives was just making the workshop happen. But there was a time when we were feeling like, are we going to get the endorsement for this? Like, are there enough people who are going to believe in this concept and this idea? And that it's within our mandate to do something like this. So, yeah, like making it happen again would be incredible.
I have a feeling you're going to be really busy in the future with this kind of work. That is great. Thank you so much. And maybe if we have time at the very end, we can ask more questions. But just in interest of time, we should move on to the next presentation. All right. So the next group presentation is entitled Arts to Change Hearts, 6 years of putting anti-colonial health humanities education to work and training new generations of culturally safer healthcare professionals in Northern BC. And we have Kelsey Chamberlin, Lisa Striegler, and Sarah DeLeo, who, as you can see, are all matching their presentation. So it has been noted and it's excellent. So thank you. And I will turn it over to all of you.
Wonderful. Thank you, Trina. And I'm glad to see that Judy also got the memo on the color coordination. Yeah, there's really good. And wow, that couldn't have been a better introduction, the previous presenters to what we're going to talk about today, which dives a little bit deeper into some of the content they were talking about. Hi, everyone, and thank you for having us. Thanks, everyone, for joining today. My name is Kelsey Chamberlin, and I'm one of the 3 folks sharing this presentation today. Initially, on the agenda, it was just going to be myself and Lisa Striegler, but we have the great honor of having Dr. Sarah DeLeo join us, which is wonderful because she is truly the mastermind behind the research and work that we're going to share with you this afternoon. And so I'll first start by introducing that the 3 of us are part of a larger team of fantastic folks at the Health Arts Research Center, which is housed within the Northern Medical Program at UNBC and led by Dr. Sarah DeLeo. And very broadly, folks at HARC gather around this idea that we've been talking about already today of using arts and humanities to promote health and health equity in rural and northern geographies, which is where many of us live. So I myself am calling in today from Smithers in Wet'suwet'en territory. Lisa is over just outside of Vanderhoof in Sykes territory, and Sarah is down in the Okanagan in Silks territory. And I'm just about to pass it over to Sarah, but before I do, I have a request that if you can, search around you and find a piece of paper and a writing utensil. It can just be a scrap piece of paper and anything to write with. And if you can't find anything, you can open up a Word document on your computer or on your phone. But as we introduce, we'll use those in a few minutes. And as we introduce, you can find that for an activity in a few moments. So I'll pass it over to Sarah now. Which you may need to unmute.
Thank you for reminding me. Just so that everybody is aware, I am in no way, shape, or form any kind of a leader. These incredible folks with whom I work make everything happen, including ensuring that we are all color-coded and matched. The Health Arts Research Center has been around since 2008, so going on 20 years. Members of our team presented this morning on placing 10 years of undergraduate medical students at the invitation and behest of Northern First Nations communities, also working in an arts-based environment. So we've really been trying to put the arts to work in Northern British Columbia for almost 2 decades now. And again, April and the Allied Health team with Northern Health, just a huge thanks for that video. If you can send it along to us, we would love to help disseminate it and promote it as well. I think that was such a beautiful opportunity to see in action what the Health Arts Research team has been doing since 2008. What we really want to do is expand on what the In Plain Sight report stated was a need for a refreshed means of understanding, combating bias, and combating really problematic strains of thought and practice in the healthcare system. That's not, however, just for patients. We do know that inspired and happy healthcare providers are better clinical providers, but we also know that we need exercises to connect folks with nature and with art. So we've been kind of doing a combination of working directly with patients who want better physicians and with healthcare providers and clinicians to use arts and other creative and humanities informed approaches to sort of think through anti-colonial ways of learning and being, to develop self-reflexivity, and to hopefully just have some fun, which again, the previous presentation did so beautifully summarize. So in the name of hopefully having a little bit of fun and hopefully doing a couple of arts-based activities, Lisa, it is on to you. With a quick shout out, again, Lisa and Kelsey were both graduate students with the Health Arts Research Center, and on board we've got Evan J, who is a new PhD student who's come into the team, which again, I just really want to emphasize new trainees across the North thinking about arts and health and creative humanities in the healthcare ecosystem will, I deeply believe, make Northern Health and UNBC a guiding example of doing out of the box, incredibly refreshed approaches to health and wellness. So with that on your shoulders, Lisa, if you could just demonstrate this, it would be great.
Thanks. So we're just going to do a little tiny exercise, a little piece of what we would do in a workshop. So looking at a potentially a historical, messy, or emotional workplace situation for you. So grab your paper and pen, open your document, and just take a breath. Close your eyes, just so that you can focus in and think of a situation, recall a situation, and maybe not the worst situation, but one from your professional life in relation to Indigenous patients, families, communities, or colleagues, when you said or did something that made someone uncomfortable or upset, or maybe you didn't say or didn't do something to intervene, or just generally felt like maybe you did not behave as your very best you. So remember the emotion that you felt in that moment. Think about where you were and who else was there. And then open your eyes, and when you're ready on your page, just write out what happened in that situation. And you don't need to go too deep. We only have a few moments for that. Okay, so I know that maybe you could keep on writing, and go ahead and keep on writing, but we're going to move on, and we'll come back to this in a few minutes. So don't put it away once you've finished writing. And now I'm going to pass it over to Kelsey.
Awesome. Thanks, Lisa. So this exercise that Lisa is bringing you through is just a tiny little taste of some of the activities that we do in these anti-colonial arts-based workshops that we facilitate. And so over the last 6 years, we've had more than 600 healthcare professionals participate, including everyone from primary care providers and frontline folks to students and educators and administrators, leadership staff, and of course, allied health providers. And we've done these workshops all across rural and northern geography, so many communities beyond Prince George, which, as was previously mentioned, is really important to get out of the urban center. And I'm pretty sure that Sarah's been a part of each of these workshops, but the rest of the facilitation team has varied through the years depending on the healthcare setting and who we might know in that community, so that we can invite co-facilitators from that community to offer local context and, importantly, connection to the ancestral and unceded First Nations territories wherever that workshop is taking place. because despite the three of us here being three white folks sharing about the work, having Indigenous facilitators and elders as a part of each workshop is really core and central to the work that we do. And so I'm going to pass it back to Sarah to speak a little bit more about the content and the structure of each workshop.
Thanks, Kelsey. Yes, just to really emphasize, these workshops are done at the invitation and behest of whatever organization or community or group that we end up working within. So we don't just come in and randomly offer a public workshop in a library and expect people to attend. This is invitational and it is set up in advance so that we often have language speakers from that territory, elders, leaders, knowledge holders from that territory who work in conjunction with us at every workshop. With that said, we very purposefully follow a messy, non-linear process, or at least that's what it often appears to be to participants. And I'll look to people like Judy to see, yeah, I think that's probably the way it went. We sort of move from one creative practice to another. We're quite purposefully not following sort of a didactic, linear, scientific modality in the delivery of these workshops, because that's something, frankly, that many clinical experts and leaders in healthcare communities in northern BC expect and feel comfortable and confident inside the confines of. And we are interested in surfacing vulnerability, surfacing critical self-reflection, and really making people a little uncomfortable in the space that they find themselves in, only to, at the end of things, wrap everything up and ensure that people are feeling incredibly heartfelt and happy when they leave. Because, as I said, behind the scenes, we actually are following quite a strict curriculum that we have over delivering it to 600 plus people interprofessionally, which is really interesting. We get really diverse groups of people in the same room. We, as we've just said, we always open with an elder recognizing territory and really deepening that what can sometimes be a bit of a glib land acknowledgement. We really go into that and ensure that participants have a full understanding of what it means to be on unceded occupied territory. We also provide people with an orientation and a background, kind of theoretical frameworks to arts and humanities-based learning in healthcare, which our previous presenters noted, there is a lot of evidence about, but people often don't know that. So we try to give that to them so that they have that under their belts. We do theatrical and creative writing practices. We do visual art production and craft making. And we always ensure that there's time for reflections, for sharing, and for sort of the surfacing of personal vulnerabilities and other discussions. So again, we are really interested in accumulative learning. So people start at point A, they kind of spiral around and wonder what's going on. But when they leave, and we have time for conversation at the end of this, I think it really all comes together in quite a holistic and positive way when folks leave the workshop. And speaking of exercises that might make you a little uncomfortable, Lisa, can you take us back to that exercise?
Thanks, Sarah. Okay, go back to your writing. This is the part that's the great part of it, because I asked you to think of a messy, emotional moment before. And so now returning to that moment about an interaction at work that left you maybe feeling like you could have done better, this is your opportunity to return to that moment and rewrite that story. So if you could redo that interaction now, what would you do differently? Take a minute, remember that moment, and how it might look if you could have a do-over. On your page then, rewrite that story in real time as though you are doing it over now. I would love to give more time if anybody needs it, but we don't have more time. So you can, again, you can finish your story, but if you have finished your story or you've gotten to the point where you've rewritten through some of it, just take a moment before we move on to just notice how you feel. And if you want to share about the experience, we can do that in the question period. And we welcome that. And thank you for everyone who took part in this. It can be challenging and awkward. So now back to Kelsey.
Thanks, Lisa, and thanks, everybody for humoring us and participating. So after each workshop, we collect written feedback forms from participants, and we often share reflections amongst the facilitators as well. And so these are just a couple of quotes that touch on kind of two of the key impacts that we've really seen over the years. And the first that we've been getting at is how art and arts-based approaches really create this sense of safety for digging into personal self-reflection and, these messy or emotional and vulnerable workplace situations. And the second is how these workshops are about more than the content that they deliver, but also the way that we hold and facilitate the workshops as really being a model for creating more systemic change and doing things differently, what Sarah was getting at as well. And so key to this, like we were talking about, is always having multiple co-facilitators whose personal and place-based lived experiences are really brought into and valued within the workshops. And we often receive comments and feedback from folks about how much they really appreciate this relational approach to facilitation. And this is actually a quote from a facilitator who joined us for one workshop, and she shared how really grounding and refreshing this approach was for her in what she has felt like is a losing fight. To you, Lisa.
Yep. Got lost there. So, to keep working in what feels like a losing fight is a pretty powerful message for arts-based relational work. And so while individual change may be possible with anti-colonial arts-based activities, barriers to implementing change at work persist within the structures of healthcare environments. Again and again, workshop feedback points to a lack of organizational support, including reprimands for speaking out, little room or time for learning built in within the work environment, and the emotional burden of carrying the weight of institutional change when you are expected to do the work on your own, and something that at times falls on the desks of Indigenous employees themselves. So we need to look at culture change in healthcare systems as a slow generational project, because healthcare organizations and leadership are made up of individuals whose decision-making and commitments to cultural safety can benefit from this critical anti-colonial work and influence change. And as one participant shared, we all play a role in the system. So now back to Sarah to finish it up.
Thanks, folks. And Trina, this is our last slide, just a very, very quick summary to say that there is increasingly an incredible amount of evidence about the import and role of arts and humanities in shifting and making transformative change in healthcare. We all know in Northern Health that there are pressing requirements around undertaking cultural safety and cultural humility training. What can we do in Northern Health that's really unique? I would argue we can use the arts in a very place-based way to ensure that experts, clinical professionals, as well as patients and community members in this very creatively inspired relational way in place help play a role in that change. I'll just offer you that the Toronto Star came out with an article just last week about how theater, thank you, Lisa, helps change the perspectives and lives of physicians, both as professionals, but in their personal lives. Again, arts are making important changes in clinical and healthcare environments. We can't, however, do that in Northern Health without multiple generous funders, which is where we'll leave it. Kelsey, do you want to say a quick summative statement?
Thank you, everybody. And we're happy to take some questions or chat about the exercise. And you can check out more of our work at our website there, healtharts.ca.
Thanks, folks. What a pleasure to have been with you. And thanks to the first presenters for we didn't come to some arrangement beforehand, but that was amazing. Thank you so much.
And I almost wore that same blouse that's in the video, so I'm glad I didn't.
Oh.
Yeah, I might have worn the same, but glad that we got the pink memo.
Yeah, this has been fantastic. So thank you so much, well, Kelsey, Lisa, and Sarah for sharing that with us and for incorporating that exercise within the presentation. That was really, again, kind of helpful to see sort of the impact that this has. And so I appreciated that. I think we have maybe one question. Does anyone have a question? And if not, we'll go to the next and you can save that, kind of formulate it, and we can ask it at the end. Sound good? All right, awesome. Thank you. And I really do hate being the timekeeper. It's not a good role for me. So I'm like, yeah.
Thank you for doing it, Trina. It's very, very important. It's respectful to everybody's time. So we appreciate you doing it.
Okay. Let's move on to, last but not least, Tammy Rogers, who is presenting on actioning commitments to decolonizing frontline healthcare Indigenous peoples in Canada. And kudos to you for floating, and I don't know how else to say it, but it's really cool. So when you're there and your presentation's there.
Something new. I thought I'd give it a try. Okay, I'm going to confess there was a second there halfway through the middle presentation where I thought, I think I may have been misplaced just because I use arts-based methods. But the way you guys wrapped it up, I just want to preface to everyone now, we did not plan this. And you'll see why. And also that I always challenge myself to give presentations, and it causes me a lot of anxiety. So you'll hear that I'll settle as I go. So just come on this journey with me. Okay. A nurse shared a story about a young Indigenous man in crisis. He was restrained in a hospital bed, injected with medications, held down by a system that didn't see him. The nurse left the unit in tears. She wished she could call an elder, offer cultural support instead of sedation, but those options weren't available. She said, I wish I had had an option to call somebody else, an elder, the way that young First Nations men respond to an auntie or a grandmother. I think that would have been so much more effective than holding him down, and I don't think it's available. This story, shared during the inquiry I'm presenting today, part of my master's research in 2024, is one of many that reveal the emotional toll of working in systems that uphold colonial norms. It speaks to a desire among providers to offer relational, culturally safe care and the barriers that make that difficult. It also points to the facilitators that can move this work from aspiration to action. This isn't about one hospital or one bad day. It's about how colonial assumptions are woven into the structures of care and why this work matters. My name is Tammy. I'm presenting from the unceded territory of the Lheidli. My father is Inca-Capim and my mother is of Irish heritage. I've worked in Northern healthcare for over 2 decades as a nurse and leader. My family's experience have shaped how I understand colonial bias in care. When my Indigenous father was recovering from an esophagectomy, his pain was dismissed. He was seen as a problem and a drug seeker rather than a person in need. His epidural wasn't positioned properly, and he was left to feel the full raw pain of his surgery. Carrying those memories into my nursing practice fuels my commitment to push against colonial structures and to call for systems where Indigenous families are treated with dignity. The In Plain Sight report made it impossible to deny what communities have said for generations. Racism in healthcare is real, and it's systemic. The Truth and Reconciliation Commission also called for action, naming healthcare as one of the places where colonial harm is ongoing. 1 year after In Plain Sight was released, the government's own follow-up found little movement on its 24 recommendations. The issue isn't a lack of an awareness. In part, our systems are built to sustain themselves, not to transform easily. In the North, these realities are magnified. Distance and constrained infrastructure mean that the same systemic inequities hit harder. But this is also where some of the most innovative community-driven solutions can grow, and we've just seen that. Systems shape how care is delivered, but systems are people, and people have a role in whether those systems stay the same or begin to shift. There we go. This project began as an action research study grounded in decolonizing methodologies. The central question was around how frontline healthcare providers in the North work towards decolonizing their practice. To explore this, we used arts-based approach designed to keep the work relational. This included photo voice, a focus group sharing circle, and one-on-one interviews. Participants included doctors, nurses, nurse practitioners, and specialists, working primarily but not solely in Indigenous health settings across the region. The study focused on understanding lived experiences while exploring the barriers and facilitators to providers. I've collectively referred to everybody as providers here, nurses and doctors combined. We turned to the literature to define the terms like decolonizing with an emphasis on action, not just ideas. Partway through final data analysis, my partner Emily and I realized something important. We had gathered powerful stories, but we hadn't actually involved elders at all in the study design or knowledge translation. That gap reflected how even well-intentioned anti-colonial work can still replicate colonial patterns if we're not careful. So we paused. We invited elders in, not to rubber stamp the work, but to help shape how we made sense of these stories. Elder Lucy Duncan reminded us there's no such thing as overburdening communities when it's done with respect, reciprocity, and proper support. She challenged us to be brave and bold, to lean into discomfort, to face our own biases, and to speak up when systems get in the way of progress. Elder Emily Henry offered something I've carried with me since. Our patients' stories are a gift. They're not distractions, not boxes to check. They're not just data, they're teachings. And when someone trusts us with their stories, we have a responsibility to receive it with care. Inviting elders in didn't make the research stronger, it grounded it. It changed how we listened and how we understood what was being said. And it's in this space that something powerful was examined, the dualities providers carry every day. When we shared the emerging themes with elders, the dualities became clear. They weren't theoretical, they lived in every decision and every interaction. And they include regulation and relational practice. Providers are accountable to policies, documentation, and regulatory standards, but the work they care most about is deeply human, sitting with someone, listening, showing up. One nurse described being torn between completing an intake form or staying with a patient in distress. She knew what mattered, the system didn't. Elders reminded us, policy shouldn't come first, people come first. Paperwork should support relationship, not control it. Efficiency and relationship. Systems reward speed. But relational decolonizing care takes time, the kind of time trust requires. One provider said, the best conversations happen when I pause and ask, how is this for you? But I never have time for that. Elders told us, if relationships matter, it must be structural, not something squeezed in between tasks. Hope and exhaustion. People come into this work because they care deeply, but the weight of colonial systems wears them down. One participant shared how they stayed late to make the system a little kinder, but it leaves them completely spent. Elders reminded us, burnout isn't a personal failure, it's a system signal. When good people are exhausted, something upstream needs to change. Voice and silence. Providers wanted to bring patient and community voices forward, especially Indigenous knowledge, but top-down decision-making often drowned those voices out. One story stood out. A patient who just needed someone to listen before any clinical instruction began. It's not complicated. Elders reminded us listening isn't the soft part of care, it is care. What mattered most in this moment was that elders didn't try to fix these dualities. They helped us learn to hold them with honesty and courage. This is also where provider responsibility comes in. These dualities can't be resolved by faceless systems alone, but they also aren't the fault of individual providers. They're lived at the front line by people who navigate them daily. When we listened to providers, what emerged wasn't just a list of barriers or policies. It was the human heart of care. One provider said, when patients feel heard and listened to in their interactions with the medical system, it creates a sense of safety and collaboration. Another shared, our clients become a part of the team and work with us when we're listening and respecting their choices and not pushing our views onto them. But participants also made it clear the healthcare system generally isn't designed to support that kind of practice. They pointed to how education, regulatory structures, and workplace pressures shape what they feel is actually possible. As one put it, there's a big gap between what they know is right and what they feel the system is set up for them to do. These tensions don't live on paper, they live in our bodies. Participants describe how they stay late, skip breaks, come in on their days off, miss personal and family events, and carry the emotional weight of trying to make care more human inside systems that often don't make space for it. One provider described it as masking systemic issues until it reaches an insurmountable tipping point. Literature frames burnout as a safety surveillance system, that something in healthcare itself is unwell. Providers were very clear about where some of these pressures come from. Many express an almost complete lack of confidence in nursing colleges, educational institutions, regulatory colleges, and even unions to address systemic racism in measured and actionable ways. They talked about tokenism in education. Our nursing curriculum has limitations in relation to Indigenous knowledge. It's situated in one semester in one course. We need to do that review inclusively and meaningfully. Another said, only offering 7 seats out of around 100 students to immerse in Indigenous community health nursing feels very tokenizing. What came out of this work wasn't a checklist of fixes. It was a set of truths to act on. Decolonizing care isn't training, it's structural change. Cultural safety workshops won't transform a system that rewards efficiency over humanity. Elders must be embedded, not tokenized. Their role isn't to open meetings with a prayer and disappear. It's to guide, hold, and shape our work. They should be present at all levels of decision-making, and their wisdom should be compensated fully. Relational care needs real resources. It can't survive on goodwill alone. Time, staffing, and organizational structures have to reflect the values they say they hold, which now leads me to question how the minimum nurse-patient ratio strategy might be leveraged to create that relational time and space for patient and family interactions and storytelling. Burnout is a system signal that requires a strategic plan. Participants also emphasized the importance of increasing First Nations, Métis, and Inuit leadership in healthcare. But they were clear, Indigenous leaders cannot be expected to fix the very systems that harm them. Healthcare organizations must ensure their safety, support, and meaningful authority, not just representation. Our elders remind us that none of this happens without providers stepping into their power, not the power of titles, but the power of everyday choices, to speak up, to build relationship even when it's inconvenient, and to collectively hold systems accountable in the spaces they work. Looking forward, decolonizing care means going beyond the level of individual clinics or single programs. It means looking at healthcare education, embedding community-led and arts-based learning, vulnerability, and reflexivity into the core curriculum, not as a single module or elective, but as a foundation of how future providers are shaped. If relationship is going to be the center of care, it has to be the center of how we teach care. It also means looking at regulatory bodies and even unions, because these are the structures that shape how care happens on the ground. Right now, a lot of commitments appear aspirational at best, symbolic or tokenizing at worst. Future and current work can push toward real accountability, workload protections for relational care, embedded elder roles, and systems that enable reflective practice. Future research might also explore how to support and sustain First Nations, Métis, and Inuit leadership within healthcare, not just increasing representation though, but ensuring safety, authority, and structural support. Indigenous leaders would need to be empowered, not burdened with the task of transforming systems that were not built for them. And we need to better understand collective provider power and responsibility. Elders remind us that providers still hold more power than patients, families, or communities. That means there's a responsibility to push the system from within, not just go along with it. As one participant said, you can't call yourself an ally if you only go along with the system. Allies push back too. So I've talked a lot today about the dualities providers carry and about the kinds of structural shifts needed to support relational decolonizing care. But before I close, I want to return to the heart of why this work matters. This is a separate but deeply connected piece of the story. After the research concluded, a student, Nurse Violet, and I worked with clients at one of our partner organizations to dream what good healthcare could look like. We use arts-based methods to create a space that didn't rely on formal or clinical language, a space where people could express their experiences and hopes in their own ways. What emerged was powerful. People shared what it feels like to be unseen in healthcare spaces and what it could mean to be met as a person, not a problem. So I just want to share just a glimpse of that with you now, because at the end of the day, this isn't really about systems or providers. It's about the people we serve. So I'll just pause a moment so that you can read the poems that were written. As we move into a call to action, we can hold these words on the page. So lastly, this is a call to courage. Elder Lucy told us to be brave and bold. That's not just for leadership tables. That's for every provider who walks into a room holding more power than the person sitting across from them. It's a call to educational institutions to prepare providers not to just fit into systems, but to question and change them, and then to be willing to actually embed those changes. It's a call to unions and regulatory bodies to make decolonizing care more than words on a website, to build it into contracts, protections, and structures. And it's a call to providers ourselves to use the power we hold differently. Lastly, our patients' stories are gifts. And if we truly believe that, then we can build systems and take personal action that honors those stories. Change doesn't come from one level alone. It comes when individuals use our power, systems make space, and communities lead the way. And that is it for me. Thank you for listening.
Thank you so much, Tammy. I'm trying to write, Sarah's reaction at one point said it all, and this was a really powerful way to end this session. And I don't think I'm sorry, I have goosebumps because I don't think I've ever seen it come together this well. I also want to say at one point, you reminded us that we need to sometimes pause in our research, and that's okay. And we need to pause and reflect in order to move forward in a good way. So thank you for that. And yeah, I'm going to open it to questions. Does anyone have any questions? Yes, Sarah.
Tammy, thank you so much. And thanks to all the presenters. Tammy, is that a link to your thesis that you've got on and could you put that in the chat, please? Because we can't grab it. Because that was a brilliant presentation. Thank you so much. And thanks for doing amazing work.
Thank you.
Yeah, that was wonderful. Does anyone have any questions for Tammy? I know we're at time, but okay, well, and Tammy has her email address there, and thank you for the link. Thank you everyone so much for your attention. Oh, sorry.
Trina, if we have 1 minute, I see Benita has her hand up.
Oh, sorry.
Sure, it was just a quick question for Tammy. So you said, I think you finished your master's. Is that correct? Yeah.
Last year.
Do you see yourself going anywhere else with this, or do you have thoughts of what's next?
Yeah, I'm literally working right now, and I didn't quite realize there's only one intake for the PhD in health sciences for UNBC a year, and it's January 15th. So there is at least one person in this audience who has an email drafted from me as I'm looking for a supervisor. I'm definitely looking to build on this work. Yeah, so thanks for asking.
That is amazing. Well, I look forward to seeing more of you on campus and seeing your work.
And Trina, we also dropped a do-it-yourself arts-based set of curriculum into the chat for multiple healthcare professionals, patients, and just anyone who touches healthcare systems in any way, shape, or form. Just that HEAL website might give you some insight into fun things when you want to think about trans people's poetry late at night, when you're not sleeping. It's an exciting website.
That's great. That's one advantage of doing this online, is that you can kind of plunk these things in and you can get your resources right away. So thanks so much, everyone. I don't have the agenda in front of me, but I know there's another session, so I shall let you all go and have a wonderful late afternoon, evening. Thank
Trina,
you.
there's a closing panel, a really exciting closing panel at 3:15. So everybody come to that.
Thanks, folks. Good to see everybody's beautiful faces. Bye.